Who is Dr. Janak?
Dr. Nitish and Dr. Janak, are you with us? Good evening, Mani sir, Prabhakar sir, good evening.
Yes, sir.
We'll go on in a couple of
Who is
minutes.
Dr. Janak?
I'll again remind him. Nitish, are you with us?
Yes, sir.
You are named Monali, man. That's why Dr. Janak,
Yes, sir.
are you
My
with us? Good
my
evening,
laptop got crashed.
No problem. I will change in a couple of minutes. So your colleague's system, is it?
Yes, sir.
Rajiv sir, good evening, sir. Nitish, I think we are 1 minute past 8. You can try
Yes, sir.
sharing your PowerPoint. Nitish, generally, we'll have about 45 minutes to an hour for the case for discussion.
Yes, sir.
The initial part will be the clinic history part. Then nobody is going to, they will allow you to present the full history. And
Yes, sir.
then you go back to the first slide and they revisit the slides with whatever questions or so. Then the same thing for the clinical examination also. Then at the end of these two things, the management part of it, evaluation, treatment, and a little bit on recent advances will be covered.
Yes, sir.
Right? Should you have any challenge in answering, please tell them so. So this is a teaching module only. There is no
Sure,
one to
sir.
pass or fail you here. So it is a learning session. So please feel free to tell if the questions asked by the examiners you are not able to answer. So they will give the answer and move on to the next section. All right.
Sure, sir.
So
Yes, sir.
we expect Professor Kalaimani to join us shortly, just winding up the case, what she is doing. And good luck to both the candidates. Nitish, you are welcome to share the PowerPoint and start. Rajiv sir,
Yes, sir.
good evening.
It's loading, sir.
Is that Nitish Chaudhary or Ayush Chaudhary?
Nitish,
No
Nitish,
problem.
sir.
Please go ahead. I'm sorry, Janak. You have any challenges, Nitish?
Yes, sir. The document is not being able to load from the system, sir.
No. You have the PowerPoint in the desktop?
Yes, sir. I have it, sir.
All right. Okay, fine. What I will do is I'll teach you to do that. Just
Yes, sir.
minimize that, close all the windows except Zoom.
Yes, sir.
Shut down everything except Zoom.
Yes, sir. Everything is shut down, sir.
Right. Now you have the green up arrow called the share button. Do you get in the Zoom lower row? You have the green up arrow.
Yes, sir.
Below, what all seen in your window?
Sir, in my
There's a
window, I can.
mic.
Sir, there's a share option.
Yeah, press that share.
Yes, sir.
What you are getting now, you just tell. Share the whole screen. Yeah, screen.
Yes, sir.
Press the screen. Now, please open the PowerPoint.
Yes, sir.
Yes. Nitish,
Yes, sir.
I wish Janak is here. I will request him to present first. Is
Sure,
that
sir.
fine?
Fine,
Okay,
sir.
please answer now. Janak?
Yes, sir.
Yeah, good evening, ma. You please start sharing your PowerPoint and then start your presentation.
Yes.
Nitish, if you can call Madam Kalaimani, she wished to join.
Sure, sir. I'll try reaching her, sir.
Yes, ma, please. Srinivasan sir, good evening, sir.
Sir, good evening, sir. Ajay, sir, good evening.
Sir, Srinivasan sir, good evening sir.
Sir, good evening, sir. Prabhakar sir, நல்லா இருக்கீங்களா?
நல்லா இருக்கு sir, நல்லா இருக்கு sir.
Good evening, Avin.
Manish sir, good
Rajesh
evening.
sir, I think you have joined in two devices, sir. Just take care of it, sir. You're okay. Whichever device is convenient to you, please.
Manish sir is from Coimbatore Medical College, la?
Mani sir, sir.
Ah,
He's in mute mode, maybe.
Sir, I did my MS in Coimbatore Medical College.
yes sir, I seen.
Janak, you have some challenges, Janak?
Almost done, sir. Almost.
Yes. Make it a full screen, Janak. Slideshow mode. Yeah. Good luck, Janak. Take care. Faculty, please take over.
Good evening, everyone. So the case presentation on Phyllodes tumor. Third year surgery resident at KM Hospital, Mumbai, presenting under the guidance of Dr. Shilpa Rao ma'am, head breast services unit. 45-year-old lady, unmarried homemaker, resident of Mumbai, came with the chief complaints of lump in the right breast since 1 month. Patient was relatively asymptomatic 1 month ago, after which she noticed a lump in the right breast, which was insidious in onset and size of approximately 3 by 3 centimeter at presentation and rapidly increasing. It was not associated with any pain or nipple discharge. No history of fever, no history of ulceration, and no history of trauma at the breast, and no history of similar complaints in the other breast. There was no history of loss of appetite or loss of weight, no history of back pain, no history of abdominal pain, abdominal distension, or passing blood in stools, no history of chest pain, cough, or blood in cough, and no history of vomiting, seizures, and headache. No history of radiation exposure in the past, and no history of intake of oral contraceptive pills, and no known comorbidities. Patient consumes a mixed diet, normal bowel and bladder habits, normal sleep pattern and appetite, and denies history of any addictions. Patient attained menarche at the age of 13 years, having fairly regular cycles lasting for 2 to 3 days and having to change 1 to 2 pads per day. Patient is unmarried and nulli gravida with no history of abortion or MTP, and her last LMP was of 1st April. No history of breast cancer in the first or second degree relatives, no history of ovarian cancer or prostatic cancer, and colorectal cancer, pancreatic cancer in the family members. Okay, to summarize the case, we have a 45-year-old lady with complaint of a painless lump in the right breast, with rapid progression in size in the course of 1 month, and with no complaints of pain or discharge, and no systemic complaints. General exam. Patient was examined in a well-lit room after obtaining informed consent and.
Dr. Shanak.
Yes, sir.
Hello, can you hear me?
Yes, sir.
Yeah, let's discuss your history first before we go to examination. So
Yes,
could you go to your you've summarized the history. What do you think you're dealing with?
sorry, sir.
You've summarized your history,
Yes, sir.
and can you tell me what are your differentials? What is coming to your mind? What is the probable diagnosis? What could be the
So, from the history, yes, sir. From the history, the patient complains of a lump in the right breast with rapid increase in size in 1 month and no history of pain and no systemic complaints. It could be a breast abscess, or it could be a fibroadenoma or a phyllodes, because considering this rapid increase in size.
Hang on, Janak. Breast abscess, 2 months, 45-year-old lady.
Yes, we can rule out the breast abscess.
No signs of inflammation. No history of
Yes,
inflammation. No fever.
Yes, sir.
Okay, what is
sir,
important in a 45-year lady with a rapidly increasing lump? What do you think? What comes to your mind first?
It could be a malignancy, sir, considering
Exactly.
the age of the
You
patient.
think of it as malignant until it's proved otherwise. Right? So what are the points in history which you will take to confirm or confirm your diagnosis or your differential? What are the points in favor and against in your history?
So the points in favor are a painless lump, a rapid increase in size, and no history of no
What
history of
was the
nipple
size when
discharge.
she first
And
noticed? What was the size when she first noticed?
it was around 3 by 3 centimeters small size, sir.
And what is it now?
It is around 10 by 10 centimeters, sir.
So in 1 month.
Yes, sir.
So you think a malignant tumor in the breast, which has increased almost 3 times, will not have any features of metastasis?
Sorry, sir.
You think that a lump which has increased so fast, so rapidly, will not have any features of metastasis? This patient doesn't have any features of metastasis.
No, sir. No, is no symptoms. Yes,
Let's
sir.
go back to your history. Let's go back to your history now. Your first slide.
Sorry, sir.
Let's go to your first slide, please, Dr. Janak. Okay. Could you tell us where this lump was in history? She could tell you which part of the breast this lump was.
Sir, right behind the NAC, sir, nipple area complex, sir.
So you can say that. Right. Okay, next. It is a painless lump. Next.
Yes, sir, it's a painless lump.
Next slide. So this rules out inflammation, trauma. Right.
Yes,
Next slide. You can say that there are no features suggestive of distant metastasis instead of writing out all of them. Right? You can't list all of the features of metastasis. Right? Okay,
yes,
next slide. Radiation. Okay. Pass. Okay. Comobs is usually medical history. Next slide, please. So you've got nothing. Next slide, please. So she is unmarried at 45. So these are 2 points which favor malignancy. One is she's unmarried and she's nully gravid, right?
Yes, sir. Unmarried and nully gravid. Yes, sir.
Next slide, please. Family history, okay, fine. Okay, next.
Can you read out what's there on the slide?
No history of breast cancer in the first and secondary relatives, and no history of ovarian, prostatic, or colorectal and pancreatic cancer in the family members.
Please continue.
Why did you target these cancers? There are a number of cancers. So your first line says about breast cancer, and your second point relates to ovarian, prostate, colon, pancreatic. So there's a cluster you have chosen. Is there any importance to this?
So we can rule out the BRCA mutations in the family members. History of BRCA.
So you're talking about BRCA related.
Yes, sir.
But there are other types of familial breast cancers too. Why didn't you then list all of them then?
So we have Lee-Fromini syndrome also.
So we just talk about brain tumors and osteosarcoma. Why didn't you mention all those? You get the point. So, I mean, it's okay to tell that you don't have any first degree or second degree relatives who have any form of cancer is good enough. But if they had, then we can look into it more pointedly. We cannot say because there are a number of genetically or hereditary linked breast cancers, we can list the whole gamut of cancers. Yeah. So that's one of the thoughts you should have, but it's a good thing that you should at least know the commonest type the BRCA is associated with this many cancers, okay? And you remember this is both applicable for men and women. It's not as if applicable only to women. So Professor Raju was rightly pointing out to the rapidity of growth, and you also admitted it is possibly a malignancy. What does it denote to you when you put two and two together? You think it is a malignancy, and you think it is a very, very rapidly growing malignancy. All right. You could have a lump which is 3 into 3 centimeters, which grew over 1 month to 3.5 into 3.5. Would that still be a malignancy?
Yes, sir. It could be a malignancy.
So when a 3.3 centimeter tumor becomes 3.5 centimeter, it can still be a malignancy. Whereas in your case, you are saying there is a 3 centimeter tumor which is becoming 10 centimeter tumor. And that again is a malignancy. Now, what is the difference between these two malignancies?
The concept of doubling time is there, sir.
Fine. I mean, that's okay. That's indirectly, that is what we are referring to. So what if it is a very rapidly doubling tumor versus a very slowly doubling tumor? What does it indicate to you?
It could be that the patient was neglecting the symptoms in the beginning.
Well,
and
it's
later they-
1 month. It's a 1 month tumor.
Yes, sir.
And in 1 month, she definitely knows it has trouble. I mean, what she neglected before 1 month, it's of no consequence when you have two definite measurements apart a month.
Sure.
So what do you think? So what are the common breast cancers that you know of?
Ductal carcinoma in situ, lobular carcinoma, inflammatory
In
breast cancer.
situ? You're talking about in situ cancer here?
Yes, sir.
In situ cancers will grow like this. How do you detect
They will be
in
small.
situ cancers?
Sir, we
Do
will have
people
no
with in
light
situ
very low.
cancers come to you saying, I have a lump in the breast? How do you detect in situ cancers?
Sir, patient will come with complaints of a lump in the breast, which with
How
associated.
many, remember, see, there are two breast cancers. There are one in situ form. There is one invasive cancer, correct? If you took 10 patients who came to you with in situ cancers, how many of them will have a lump? All the 10 will have a lump? Janak, you remember that in situ cancers are screening mammography detected cancers. How do you do screening for breast?
Screening, we do a USG breast, and we also do a mammography, sir.
So you do a X-ray mammography?
Yes, sir.
Yeah. So when they go for an X-ray mammography for screening, do they have a lump?
Sir.
The simple question, when does she go for screening? When she has a lump or when she does not have a lump?
Ma'am, screening should be done before before she has a lump.
Yeah, that's
When
what
she
I was
has a lump,
asking.
it becomes a diagnostic.
Yeah.
Exactly. So when they have no lump and they go for a mammogram, what do they pick up?
Sir, they can be the diffuse swelling can be seen in the breast, and where there are and calcifications can also be seen.
What type of
It points towards
calcification?
malignancy.
What type of calcification will point to malignancy?
Sir, microcalcification, sir.
Very good. So you have to make a distinction in the calcification. And I'm assuming you're talking about architectural distortion that is
Yes, sir.
picking up. So these are the two things here. So if that be the case, they will do how will they biopsy when it is impalpable? They took a mammogram, they found a microcalcification, And when you feel you can't feel the lump, how will they biopsy it?
By USG guided, sir. If it's a small lump, which may not be palpable, but it can be picked up on USG, we can go for USG guided FNAC, sir.
Yeah, that's a smart answer because many of the microcalcifications can be picked up by ultrasound. But what if it is too small for the ultrasound to pick it up? Anyway, so you have to do what is known as a stereotactic biopsy, right? So just because you brought up an irrelevant answer called in situ cancer for a lump which is growing 3 times in 1 month duration, you understand how you can get trapped in an examination? So you must give very pertinent, relevant, pointed answers to the case you're presenting and not from some theoretical textbooks. Okay? All right. Go ahead.
Yeah, Dr. Janak, I just like to ask you one quick. You said
Yes,
that
sir.
microcalcification is a sign of malignancy.
Yes, sir.
Can you? Yeah. Why is it micro? Why not macro? Why is microcalcification a sign of malignancy, not macro?
The macrocalcification is mostly seen in benign conditions. The micro is points more towards
Why? There must be a
malignancy,
reason
sir.
for it. Why is it seen in malignant conditions? You have an idea? Because of cellular death. In malignancy, there is large turnover of cells, and some cells are dying, and these cells get calcified, and that's why you get microcalcification. There's no deposition of calcium anywhere because of chronic inflammation. Okay?
Yes, sir.
Yeah, that's the reason. Right. So next slide.
Examination? No.
Yes,
Just the examination.
Okay. So no, ma'am, just what do you think now? You've gone through all this discussion with Sir, with Professor Mani. Now, what do you think?
sir. The lump can complain of lump in the right breast, which is rapidly progressive and no symptoms.
And no other symptoms.
Yes, sir.
So what do you think?
Talking about the tumor doubling time. Do you know what is the tumor doubling time for the cancer breast?
Yes, sir. Doubling time. So patient, for example, if a patient presents with a lump of 1 centimeter lump, pathology has already started around 10 years before. So for it to come as a 1 centimeter lump, sir.
So what is the tumor doubling time for the breast? How many days, how many months, weeks, years? It's approximately 100 days. Okay, approximately 100 days. And for getting a 1 centimeter lump in which becomes palpable, it will require at least 30 doubling share. So that's around 5 years. Okay, for just having a palpable lump of 1 centimeter. Now you say that in a 45-year female patient, as the abscess as the first cause for the, why you have put the abscess there? And if you are thinking of the abscess there, what type of the abscess you are thinking?
Considering the rapid size and it could be abscess, but because of no systemic no other signs and symptoms, we can rule out, sir.
What is a cold abscess?
Sir, collection of pus without any systemic signs, sir.
And where is usually in a patient with a breast lump, where do you find the cold abscess? What is the usual site for that in the chest? Is it in the breast or it is behind the muscles?
Sorry, sir.
The cold abscess which is there, or like the tubercular region which is there, it will be a retromuscular abscess will be there. So you may feel a similar lump, big lump may be there if you want to explain as an abscess there, as a cold abscess because of that. And do you think the carcinoma is more common, or the Phyllodes tumor is more common?
Carcinoma is more common, sir.
So why you have not put the DD of the carcinoma in your 3 or 4 what you told? You did not mention about the carcinoma here.
Mentioned it later, sir.
When a
Mentioned it
45
later,
year
sir.
perimenopausal female, okay, there's a lump is there and rapidly growing lump, the carcinoma should be the first diagnosis.
What age group phylloids come?
Perimenopausal.
Right? Okay, tell points in favor. Sir, coming to your diagnosis, Janak, you tell what are the points in favor of your diagnosis?
Sorry, ma'am.
What's your first diagnosis?
Sorry, not audible, ma'am.
What's your first diagnosis? You can't hear me still?
Yes, ma'am. Yes, ma'am.
What is for your first diagnosis? What was your first diagnosis?
First diagnosis, it could be a phyllodes, ma'am.
Yeah,
And,
that's what.
or malignancy.
A 45-year-old lady, perimenopausal, nulliparous. You will think of phylloids or something else is the question here, right? You just think and tell. What will be the most think of? And that's why I asked which age phylloids tumor commonly occurs. Now answer these two and you'll arrive at a proper diagnosis.
Both present in the same perimenopausal age group, but we can consider both could be the differential diagnosis. We will need further investigations and further examination to rule out which is which.
Okay, go on the examination now, yeah.
Yeah. Good example.
Patient examined in a well-lit room after informed consent in the presence of a female attendant. Patient's conscious, cooperative, well-oriented to time, place, and person. Build was average. Afebrile, patient was afebrile. No pallor, icterus, clubbing, cyanosis, edema, and generalized lymphadenopathy. Patient's vitals, pulse 78, BP 140/90 in right arm in sitting position, respiratory rate of 18, height of 160, weight of 70 kg, and BMI 27.3. On inspection, patient done after proper exposure from neck till waist. Patient examined with arms by side, arms raised above the head, hands over the waist, and bending forwards and in supine position. On examination, the right breast appeared higher and larger than the left breast. Right areola appears significantly enlarged, and the right nipple was cracked and slightly everted in comparison to left, with no nipple discharge. The surface appeared lobulated, and the skin over the right breast appears stretched and shiny with the veins dilated, and no ulceration or no skin changes were seen. Left breast appears normal, and on palpation, all inspectory findings were confirmed. Right breast, there was no warmth or tenderness. A single lump of size, 10 by 10 centimeter, involving the lower and inner outer quadrant of the right breast, which was seen, was palpated, with uneven surface and variable consistency. Lump moves along with the breast tissue. It was not fixed to the skin or chest wall. And the nipple was cracked with no nipple discharge and no lymph nodes palpable in bilateral axilla and supraclavicular lesion, and left breast was completely normal, sir.
Do you have any picture?
Patient did not give consent, sir. Patient.
What did you say? Axilla?
Axilla, no lymph nodes palpable.
No lymph nodes in axilla. Okay. So not
you-
fixed to the pectoral muscle also?
No.
You didn't mention, right?
I have mentioned now.
You mentioned. Okay. So not fixed to the muscle, but a huge swelling, right?
Yes.
Okay. Skin is pinchable, you said.
Purity orange is present?
No, sir.
It's not. Okay.
Did you mention that it's present or absent?
Sorry, ma'am.
Did you mention whether it's present or absent? Purity orange and
Yes, ma'am.
you mentioned? Okay.
Yes, ma'am.
So you have to mention all these things: satellite nodules, purity orange, puckering. Okay, all these things you have to mention. But you said
Yes,
there are dilated veins, right?
Yes.
Yeah. Okay. Fine. Anything else you have to examine?
We also did a PV and rectal examination, ma'am.
No, axilla you said. Supraclavicular fossa?
Yes, ma'am. We have examined supraclavicular region also mentioned.
Okay. Fine.
Moving on to systemic examination.
Just before that, can you just explain to me what is the importance of there being dilated veins and the absence of purity orange? Does it give you any clue?
The dilated veins, because there's a lump in the breast, which on the lump in the breast, the cutaneous veins will dilate, and the PD orange is because of the involvement of the dermal lymphatics.
Yeah. So you have a 10 centimeter mass, and this mass prefers to have dilated veins and does not prefer to have purity orange. Does it indicate anything to you?
Sorry, sir.
You can't hear me?
No.
Did you hear
Yes,
me?
I can hear you right. Yes.
Yeah. So I'm asking, is the presence of dilated veins in the absence of purity orange convey anything to you in a 10 centimeter breast mass? So if you had a carcinoma, which is 10 centimeter size, how often do you get dilated veins? So generally dilated veins are not a feature of carcinomas, okay? And there is a reason for it, okay? But why do you get purity orange in a carcinoma?
Because of the involvement of dermal lymphatics and ligaments of Cooper, sir. The skin is pulled and you get PD oranges, sir.
No. Purity orange is not due to involvement of ligament of Cooper. Okay, you said it's subdermal lymphatics involvement. That's right.
Yeah.
Ligament of Cooper involvement, does it cause, what does it cause to the skin now that you brought that question?
Sorry, ma'am. It causes puckering of skin.
Okay, you should be careful because puckering does not mean involvement of the skin. Please remember that. Okay, there are two different things. Purity orange is skin involvement, whereas puckering is not skin involvement. And it's involved in your staging. So you have to be very careful when you tell. That's how you got caught, and sir took you in this different direction. Right? You have to be very careful when every word you utter, you have to think. It's okay if you want to take some time. Whenever a question is asked, take some time, understand, and then answer. Okay, that's always
We
better.
have dilated veins, we have absent purity orange, and we have no axillary lymph nodes in a 45-year-old lady. So what do you think now?
Could be, sir, like it could be a phyllodes, or it could be still be malignancy, which is not yet which we could be a malignancy or a phyllodes, yes, sir.
No. What malignancy? You said phyllodes. You're okay, but you're not adding. Phyllodes is benign or malignant?
Benign.
Benign always?
No, ma'am, not always. It can metastasize also, but most of the mostly it is
benign or malignant, right? So your answer lies there.
yes.
You agree it's malignant or not?
Yes, sir.
So if you took, okay, so you're a little doubtful, I think. Okay, so majority of your Phyllodes tumor are supposed to be benign, you're right. So that will be amounting to 60% or so. Maybe 20% would what we call as borderline, which means it's neither here nor there. Another 20% we would have a malignant Phyllodes tumor. Okay, so you can have a malignant Phyllodes tumor also. The proportions are like 20%. Okay, so 60% is Phyllodes, so no wonder you're thinking more in terms of benign, but not so in a case which is 10 centimeters in size, and not so in a case which started as 3 centimeters and became 10 centimeters in 1 month. Not so in a case which has such dilated veins, and not so in a case where there is no UD orange and there is no axillary lymph nodes. So if all these things are going in your favor, and so you shouldn't have any hesitation in calling this as a malignant Phyllodes tumor. All right?
Yes, sir.
And you can be very categorical about it. All right? Yeah,
So now
go ahead.
what's the diagnosis? It's phyllodes, carcinoma, or malignant phyllodes.
It could be malignant phyllodes, considering the size and the findings we have on the examination. It could be a malignant phyllodes.
Mainly, see, whenever you give points in favor of your diagnosis, you have to start from the history, the age. So, perimenopausal lady, and then history of lump rapidly increasing in size in 1 year, and then your findings of a huge lump with dilated veins. Okay. Now, since you are thinking it is phyllodes, malignant phylloid, why can't you give a diagnosis of carcinoma of breast, such a huge lump?
From the examination, from the age of the patient and whatever we have on the examination, there were no lymph nodes palpable, ma'am. And lymph nodes, if there are no lymph nodes palpable, we cannot say it is a carcinoma.
What is it?
Although
Not necessarily, doctor. You can have a lump without a lymph node. So it
yes, sir, we
doesn't.
can have a lump without palpable lymph nodes, but for this big this big size of the mass, and if there are no lymph nodes palpable, we can probably say, and we will require further investigations to rule out. But
Don't go to
from the clinical
investigation.
examination,
Don't go to investigation. You're still in clinical diagnosis. You are right. You are coming to the point. Such a huge lump, no lymph node. I don't want to think of carcinoma. So I want to think of what?
phyllodes,
Not phyllodes. You have to say,
benign lesion.
you have to say sarcoma. Okay. So those spread by hematogenous spread. So you will not find for such a huge lump, not involving the skin. Sir gave you all the clue. Skin, there is no purity or range. There is no fixity to the underlying. But a huge lump and no lymph nodes. All this goes in favor of what?
And stretched and shiny.
Yeah.
Why it is not a giant fibroadenoma?
It can be a giant fibroadenoma, yes, sir. But this rapid increase in size is not seen in giant fibroadenoma, sir.
And age group also, no?
Yes,
Which
yes, ma'am.
group
Age group also. It's
fibroadenoma?
not. It is seen in fibroadenoma usually seen in young age group.
So you have to tell always systematically. You have to go from demography and then the rest. Okay.
When you call it as a giant fibroadenoma?
When the size is more than 3 centimeters, sir.
3 centimeters. That is the indication for surgery, that you should go for surgery if it is more than 3 centimeters. But you do not label giant at that point. Giant is at least 5 centimeters. More than 5 centimeters is a giant fibroadenoma.
Okay. So now you said it is phyllodes, malignant phyllodes. What kind of malignancy is phyllodes? What type pathologically? Okay, what is the type of, when we say carcinoma, what is it? What is the pathology you see? Most common pathology you see.
What is the cell of origin, doctor? That's what your professor is trying to ask. Which cell is it arising from? Carcinoma arises from which cell, and sarcoma arises from which cell?
Sir?
Carcinoma arises from which type of cell, and sarcoma arises from which type of cell?
Sarcoma arises from connective tissue cells, sir. The stromal
Very
cell.
good. Very good. And carcinoma?
From usually from epithelium cell.
Very good.
Ductal cells.
Very good.
What
Okay.
type of the carcinomas are they? When they are arising from epithelium, what type of the carcinomas are they?
It's adenocarcinoma or squamous cell carcinoma, like that sir is asking.
You have to be little quick, Janak.
Okay, they are all adenocarcinomas, isn't? Okay, when we say it's a ductal carcinoma, invasive type, all those are the adenocarcinomas basically, you know? Yeah.
Okay,
Then
so you
it can be
understand
ductal or the lobular variety, but they are all adenocarcinomas.
Okay. So now you know the points in favor of your diagnosis. Why is it a sarcoma and not a carcinoma? Got it? Such a huge lump without involving the skin, without penetrating into the deeper structure, without having an axillary lymph node, you will think of sarcoma because their spread is hematogenous mainly. Okay? If it was carcinoma for this size, non-involvement, skin not being involved, axillary node not involved is unlikely. So in both
Difference
it is more
between
common.
skin ulceration. Sorry, madam.
Yes, yes. Please
Let's
go
say
ahead.
we have an overlying skin ulceration.
I was expecting that question.
What would be the difference from a carcinoma and a sarcoma?
So if there's overlying ulceration, it could be because of pressure symptoms. The mass is too big and it's causing pressure.
So what is the type of ulcer you'll get in sarcoma, and what will be the type of ulcer you'll get in a carcinoma?
What is probe test? PROBE, probe test. Any idea, Janak? Probe test? No idea.
Okay, Janak, it's very important that you read DAS, Clinical Methods DAS. You have to read. You have to know in and out of that book, every line, every page. Most important. You cross that, then only the next level of questions will be asked. But most of the questions even today are your examination. Very important. Okay. Which your current generation is definitely ignoring that basic understanding and learning. You must get back to those basics. Please go read. All these questions are there in that.
In which pathological condition of the breast, skin will be infiltrated? In sarcoma or in carcinoma? In which condition it will be stretched out? In which condition it will be infiltrated?
It will be infiltrated in carcinoma, sir.
So what will happen?
The skin will be puckering of the skin, and skin retraction will be there, sir.
So in a clinical staging, skin involvement is what stage, though?
Involvement is T3 stage, sir. T3.
T3.
Can you? Because you're on Phyllodes doesn't mean that you can forget carcinomas, okay?
Commonly,
Ask your friend, don't worry. You can ask some friend and tell me. Don't worry. So what are the T stages of carcinoma breast? Can you tell us?
What is T1, T2, T3, T4?
Or do you have T5 and T6 also?
T1.
Huh?
No, sir, T1 is less than 2 centimeters. T2
Good.
is 2 to 4 centimeters. T3
2
is
to?
more than 4.
2 to?
2 to 4 centimeters.
Not 4, dog.
5 centimeter.
5.
Three. T3 is?
T3 is sir, more than 5 centimeter with involvement T3A.
No, T3 is more than 5 centimeter. T4 only is any size. Then A, B, C, and D,
AB.
depending on chest wall,
Chest
skin,
wall, skin
both.
fixation, and both.
Which one is T4A? Chest wall or skin?
He doesn't know. It's okay. Go and read.
Chest wall.
Go and read. Doesn't matter. Okay. So the 4B is the skin involvement. So I was supposed to ask you what type of skin involvement will constitute T4B, but you should go and read what is T4B before you can answer that question. Okay. Okay, we can move on, I think.
Things. So what other? Just quickly wind up saying what investigation you want to do. What investigation you will do first?
I would like to do a USG breast and followed by a USG mammogram to look for
USG mammogram.
Sorry, USG breast and a mammogram separately. Sorry.
It's a
The
10
lump is
centimeter
involving
mass.
the whole breast, right?
Yes.
How is a mammogram done?
The breast is placed between two plates, and an X-ray film is taken, sir, in
Good.
2 views,
Very good.
medial,
Very
lateral,
good.
oblique, and craniocaudal.
So you think this breast lump will yield to a mammogram like that? Never mind. Okay, so you do a mammogram. Fine. What's more important in this case? Would you like to, now your clinical diagnosis looks like I'm understanding it is malignant phyllodes. Is that right, or you still have your doubts on that?
What is sonomammography? Jana, what is sonomammography?
Sonomammography, sir, both are integrated, and mammography and sonography are used in together, sir.
How both can be integrated means mammogram machine is different, ultrasound machine is different. So how can you integrate them? Sonomammography basically means it's an ultrasound of the breast. Okay, it is nothing like the mammography, but you are doing the high resolution in that, and that is why specifically for the breast it is called as a sonomammography. So basically the machine which is used for the sonography is not mammography. It is the ultrasound machine which is there. Okay. And what is the usual frequency of the probe which is used for that? Like when you're doing abdominal ultrasound, do you know what is the frequency of the ultrasound? Frequency of that probe?
3 to 5 megahertz.
Yes, 3 to 5 megahertz, yes, for the abdomen. Yes. For the superficial structures like thyroid, breast.
Less or more? Less than 5 or more than 5? Oh, no. It's more. So you should have higher frequency for more surface structures. Okay.
So what is the basic difference between these type of the frequencies which are there? Why in the superficial structures you are having the higher frequency? Okay, the higher megahertz if it is there, then it means that it has got more
penetration
resolution and less penetration there. Okay. So like if you're doing the endoscopic ultrasound where you use about 12 to 15 megahertz. Okay. So there is a less penetration, but more resolution is there. Okay. Yeah. So sonomammography is a high-end ultrasound for the breast, and that is labeled as a sonomammography. Okay, what other investigations you want to do?
Will you do core needle biopsy for this breast lump, 10 into 10 centimeter, involving the lower inner and outer quadrants of the right
Yes, sir.
breast?
Yes, a two-cut biopsy would be preferable. Considering the size, it would be easy to take a biopsy, sir.
How many cores you will take?
Around 4 to 6 course.
Under what anesthesia?
Local anesthesia, sir.
Would you like to have guided, or would you like to do it without guidance?
Sir, we usually consider under USG guidance if the lump is too small or
Okay,
not
this
very.
patient has 10 centimeter mass.
For 10
Some
We will go
centimeters.
without guidance, sir.
Yeah.
without guidance.
And
Why
you
not with guidance? You must remember, doc, when it is too large a mass also, you can have necrosis in the tumor. So you better have a guidance to go through a viable tumor so you get better diagnostics. Okay, there's no point in plunging your needle and getting just necrotic material. All right, and in a 10 centimeter in a rapidly growing tumor, you do anticipate there will be a large deal of necrosis within the tumor. So guidance is not necessarily for smaller lumps. It's there for bigger lumps as well.
What
Yep.
will be the
variable consistency, right? You mentioned, right, variable consistency.
Yes.
All the more reason. Means there is some area of necrosis also, right? Okay.
on what basis you will tell that it is a borderline or it's a malignant or it's a benign one? Professor Manisar is telling that 3 types of Phyllodes tumor is there.
That doesn't matter. I mean, that is okay. The pathologist is going to say that, so you don't worry about that. But if the pathologist says it is malignant, the question is whether you want to agree with them or not. That is the clinical perspective that you should provide. Let's say they say it is benign. Would you agree with them?
Yes, sir.
So you need to know some basic characteristics so that you can ensure that your clinical perspective is captured properly in a pathology reports as well. Okay, they must go complementary to each other.
So benign, we can say it is benign if there are no palpable lymph nodes, no.
We are talking about Phyllodes tumor, doctor. Why are we talking about lymph nodes here? We are talking about Phyllodes tumor, which is either benign, borderline, or malignant. There is no question of lymph nodes in a stromal tumor. Why are you bringing in that topic once more? You get the point. A stromal tumor, like your madam said, when it transforms into malignancy, it transforms as a sarcoma. And sarcomas, by nature, prefer to go to the lungs. Okay? You understand? And why would you expect lymph nodes to be there in this case? I think you're getting too tensed and stressed out with so many of us. Yeah. So I think you should learn to relax. And this is an exercise in good faith so that, with all such pressures, you still will be able to stand your ground and reason out your case properly. And that you can do only if you have all the unbiased approach to present a case. If you're already biased in your mind, that this is what is going to be, then you get easily offset with any questions coming from other directions. Yeah.
Okay. After true cut biopsy, what next you want to do?
True cut biopsy will confirm our diagnosis, and then after that we will go for further management for surgery.
Now, what are the investigation you don't want to do? If it turns out to be a sarcoma, what else you want to do?
Sir, just now told that it can spread. It can metastasis
Answer
to the
was
lung.
given
Yeah.
already. So what you should do?
Get a look for metastasis in the lungs. I would like to advise a CT chest.
Yeah, CT thorax is a must. Okay. If you are suspecting a sarcoma, CT thorax is a must. Most common is the lung metastasis, which has been already explained. What is the most common modality of death in sarcomas? Everything is in only one answer.
So
The
just
cancer
before.
is
Good. Every cancer will they die of metastasis. Nobody dies of local disease. Okay. The type of, just to wrap it up, a CT chest, looking for lung metastasis. Is there a difference between metastasis from a carcinoma to the lung and metastasis from a sarcoma to the lung? Is there a difference? Let's say they call this as a cannonball shadows. What is it?
Why it is in the shape of the cannonballs? Not in liver. We cannot see the cannonball secondary metastasis in the liver, but in the lungs it is possible. Why? What are cannonball metastases?
involvement of the lung parenchymas.
The resistance given by the surrounding tissues in the lung is the same. That's why it is cannonball. Okay? Yes.
Is it coming from a carcinoma or a sarcoma? Cannonballs.
Carcinomas.
Oh, no. Sarcoma, doc. Okay. It's sarcoma. So in a carcinoma, you won't get cannonballs. You may get what is called as pleural or some parenchymal metastasis, but not in cannonball type. Okay. So that is something can be used as a spotter also for you if there was an X-ray with cannonballs. Okay, you must be able to relate to it. Okay. Good show.
Wind it up. Treatment.
Surgical management, ma'am. Will calculate. If the lump is too large, we can go for
You
a
have the
mastectomy
patient
or
with
small.
you. You have seen the patient. So you just
Yes,
tell for that patient what you will do.
for the patient, we did a wide local excision, ma'am.
You're suspecting sarcoma and you want to do wide local excision. And for a huge tumor of 10, what is the tumor breast ratio? All that have you looked for? Is her breast bigger than the lump? Or the lump is bigger than her breast?
Lump is bigger than the breast. We can go for mastectomy.
So where
What
is
type of mastectomy?
Simple mastectomy, sir.
What do you mean by simple mastectomy? In what way it is different from modified radical mastectomy?
So we will not be removing any nodes because there is no nodal involvement. We will not be removing any nodes. We will remove the breast.
Nodes and mastectomy has no relevance, doc. Mastectomy is removal of the breast.
Yes.
Nodes are entity separate, wholly different entity. So within mastectomy, the professor is asking what is simple and what is modified radical and what is radical. And here in a case where you think there is a 10 centimeter, potentially a sarcoma, wherein it is bigger than the breast, what type of mastectomy will you do? And what is the goal of your mastectomy? I mean, you're agreed that you can't do wide local excision in this, right? Are you agreed on that?
Can't. The lump is bigger than the breast. Yeah.
Okay, so in the mastectomy, there is so much of skin you should decide to remove. So much of surrounding soft tissue for clearance you need to remove. And so much of deeper clearance you should give. So between carcinoma and a sarcoma, which we should give more clearance?
We should give more clearance. We should dissect more. We should dissect the surround tissues more, which give which towards
Doc, for
carcinoma.
breast, carcinoma breast, will you give 5 millimeter or 1 centimeter margin?
1 centimeter.
Or will you give 2 centimeter?
So we'll give as much like 1 to 2 centimeter margin. We'll give, sir.
For carcinoma. So how much will you give for sarcoma? Just give a number, doesn't matter. Is it less or more?
More, sir.
More. So more than 2 centimeters, how much will you give? So let's argue anything more than 2 centimeters. What will be the deeper clearance if you want more than 2 centimeters? Do you remove the chest wall, the ribs and the pleura and everything? You can't, right? Yeah. So anyway, for this case, because it may be mobile over your pectoralis major muscle, but your pectoralis major muscle should certainly come out as part of clearance. Maybe also minor, so it is essentially going to be working out like a radical mastectomy. Okay, and because you're going to lose a lot of skin, you have to give clearance in the skin also, 2 centimeter clearance for the overlying skin as well. So you must plan for cover of that skin defect. Okay, so you'll lose a massive amount of skin, and therefore you should plan for a skin cover as well. Okay, so that means you should use some flap. Right, you can't use a graft, skin graft, correct? Why you can't use a skin graft?
Because there's loss of tissue, sir. We have to compensate for the loss of tissue that we have removed. And
yeah, so you put a skin graft over the ribs. What is the problem?
Since considering our patient is young and we are doing resection with lot of resection, the tissue loss will be
The
there.
answer is that you should plan for subsequent treatment like radiation. So if you have sarcoma, you may require to radiate the tumor bed. So if you did only skin graft, you won't be able to deliver radiation. Is that clear?
Yes, sir.
Yeah, that's about it.
Okay. Fine. So you read up all these things, what was discussed with you, Janak. Okay, starting with DAS for examination, and then what are the types of carcinomas and sarcomas and different types of phyllodes. All these will be asked for you for a breast lump. Okay, benign and malignant conditions, everything in detail, including their pathology, will be asked. Fine. Okay. So, Dr. Kanagavel will move on to the next case, or any other questions from the examiners? We'll stop here, sir. Fine,
Yes.
sir. Okay, Janak, all the best to you. Don't worry.
Thank you.
So don't worry about it. Just read up whatever was discussed with you. Right?
Last question. What is the literal meaning of phyllodes?
Sir, leaf, like a leaf.
Leaf like, okay.
Leaf like a.
Leaf like, yes.
Leaf-like will be present in the microscopic features or in the macroscopic feature?
Say microscopic, histopathic, microscopic.
Yes. What is the difference between rapid increase and sudden increase? Rapid means it will be in months together. Sudden means 2 days, like that. Okay. You are told that some painful lumps of the it is not associated with the pain. Which lump will be painful lumps in the breast? Breast abscess, isn't it? Yes.
Yes, sir. Breast abscess will be painful. Yes.
Okay, right. Good. Thank you, Jana.
Thank you. Sir. Thank you. Sir.
Thank you.
Thank you.
Sir, next case. Kanagvel, sir. Who is the next candidate?
Sir,
Yes, sir.
we have Dr.
Nitish.
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 is Kalevani madam's postgraduate. In the meantime, Janak, do you have any questions to ask? Doubts to be clarified? Thank you, Dr. Janak. I
Thank you,
can give my inquiries to Madam Shilpa also. Now we move on to the next presentation. Can you please unshare, Dr. Janak?
Can you
Yes, sir.
please excuse me, Dr. Kanagvel?
Yes, ma'am. Yes, ma'am. Please.
Have another meeting. Yeah, thank you.
Yes, ma'am. Yes, ma'am. Yes. Jailal sir, good evening.
Yeah, good evening, sir. Good evening.
Good evening, sir.
Good evening, sir. Kindly excuse
Good evening,
me.
madam. Kalevani, madam. Good evening.
Bye, sir.
Mani sir, thank you, sir.
Jailal sir, good evening, sir.
Good evening. Good evening, Prabhakar.
Sir.
Can I go to the first slide?
Good evening, respected faculty. I am Dr. Nitish.
Nitish, you please switch on your video, ma.
Nitish, your college is in Bangalore.
Yes, sir.
Yes, sir. You have any challenges in doing that, Nitish?
Yes, sir.
What's happening? Please unshare now.
Camera. Yes, sir.
Right. Switch on your video now.
So please guide me, sir.
No problem. No problem. Please switch on your video now. On the left
Which
lower
one,
side,
sir?
you have audio and video, no?
Yes,
Lower
sir.
most.
On
Please
that,
switch on the video. Yeah.
I want it, sir, but it's not showing.
What device are you using, ma?
The laptop, sir.
Laptop only.
Yes, sir.
You have the camera enabled there? In the...
Yes, sir. I have enabled it.
Can you try logging off now and again join now? Repeat.
Yes, sir.
Jaila sir, Vikram Kati has accepted.
Oh, great, great.
He wants an official mail alone to apply for the leave and other thing. Being a dean, he wanted to take it.
Now, how do we send that?
Sir, that's
ASA
Mari has to send, sir. I will give, I'll draft the mail and send it to him, sir.
Okay.
Or if you wish, I can send making a copy to you, President and Secretary also. I can do that.
Yeah,
But,
please.
yes, sir. Yes, sir.
Sir, am I visible, sir?
You're perfectly visible, sir. Please share your slides, sir. Not listening?
No, sir. No, unable to share, sir.
Okay. Now listen to what
Yes,
I'm
sir.
telling.
Yes, sir.
You
I got
press
it.
share screen. Great. Now open the PowerPoint here. Good to go. Good luck. Please start.
Not audible.
Kana, unmute yourself. Unmute now.
Yes, sir. Am I audible, sir?
Yes,
You're
yes.
perfectly audible, sir.
Sir, is my screen being
Yes.
shared, sir?
Yes,
sir.
go ahead. Go ahead.
Yes, sir. Yes, sir. Sir, 42 years chief complaints. A 42-year gentleman who is a daily wage worker belonging to Cotton Pete, low socio-economic status, came with complaints of pain in left lower limb since 5 months, sir, and blackish discoloration of left foot and leg since 3 days. History of present illness. Patient was apparently normal 5 months back. He developed pain in the left foot, crampy type, initially intermittent, gradually progressive. Pain increased on walking about a kilometer, relieved on rest initially. Claudication distance reduced to 500 meters in the last 1 month and eventually progressed to rest pain. Sir. There is a history of night pain, which is relieved by hanging his leg down. Blackish discoloration of the leg started initially from the toes and advancing to foot and till the mid legs. History of hyperesthesia in the foot in the initial days. There's no history of trauma, ulceration, and discharge. There's no similar symptoms in the right limb. So no patient didn't have any history of fainting, blackouts, blurring of vision. No history of chest pain, palpitation, dyspnea on exertion. No history of postprandial abdominal pain, no history of color change or pain in the upper limbs on exposure to cold. Uh, Comorbidities, patient is a known type 2 diabetes mellitus since 12 years and a smoker for last 20 years. These are the clinical pictures of the patients. Sir, am I audible?
Yes, yes.
Yes, go ahead.
Sir, past history. Patient is a known case of type 2 diabetes mellitus on tablet metformin 500 mg twice a day, and known case of hypertension on tab telma 40 mg twice a day. Patient has a history of a burns sir, involving the entire left upper limb, upper back, and bilateral lower back at the 6 years of his age, sir. So he has undergone abdominal flap cover surgery for the dorsum of the left hand. No history of similar complaints in the right leg, sir. In personal history, patient consumes mixed diet, normal bowel bladder, altered sleep, a smoker for last 20 years, 10 cigarettes per day, 20 pack years of life. Alcohol, he consumes 180 ml of whiskey for the last 20 years, sir. So family history, he is married and having 2 children. No similar illnesses in the family, sir. Summary of the history is 42 years male, diabetic and smoker with left limb claudication pain, advancing to rest pain, and dry gangrene, suggestive of ischemia of the leg. My probable diagnosis will be peripheral arterial occlusive disease, secondary to either thromboangiitis obliterans and atheromatous changes. Sir, should I go for the?
Yeah, can you go to the slide to starting again?
Yes, sir.
So you said the pain. No, next slide you can.
Yes, sir.
And the complaint, you said the pain started in the lower limb.
So
now you are saying the pain developed in the.
pain started in the foot, sir, and gradually it went to the calf.
So
calf
what is the reason for the pain in the foot?
Sir, pain in the foot secondary to this one, sir, gangrenous changes. Previously, sir.
Say 5 months back, he's normal
Yes,
apparently. Suddenly he developed a pain in the foot. That is a starting.
Yes, sir.
So gangrene developed very late.
Yes, sir.
So what is the reason for the pain in the foot?
Sir, secondary to the occlusion of the small vessels, sir.
Okay, so you mean to say it's a claudication pain?
Yes, sir, claudication pain, sir.
So where do you get the claudication pain? What is claudication pain?
Sir, claudication pain when there is a demand mismatch supply of oxygen and
For what?
increase,
For whom?
sir, for the
Which component?
tissue and increased in
Which tissue? Which tissue?
in the muscles, sir,
Which muscles?
foot muscles.
Okay, so foot muscles is a problem.
Sorry, sir, increase in substance P.
No, I understand the reason, but I want to understand the claudication pain will never start in the foot.
Yes, sir.
So it is the bulk of the muscles which is going to get in the problem.
Yes, sir.
So always, depending upon the site of occlusion,
Yes, sir.
the pain, the most distal part where the pain you can felt, and the most commonest part is the calf muscle.
Calf muscles.
So when you say the history, the foot, it is absolutely that you are missing the point and what you are understanding the claudication pain. So never ever make the postgraduate should never make this mistake. The pain started in the foot. What is foot?
Sir,
Foot starts from where?
Sir, from the toe till the ankles.
Okay. So there you don't get a pain. So
Yes,
what kind of pain you get in the foot commonly?
Sir, paresthesia, pins and needle sensation.
In the vascular, peripheral vascular disease, and what kind of pain you get? It can be the rest pain.
Rest pain, sir. Yes, sir.
So rest pain starts in the foot. Why?
Sir, accumulation of a P substance.
Rest pain. Rest pain is nothing to do with accumulation of P substance. What is rest pain?
Sir, cry of a dying nerves.
So the nerve which is going, which nerve will die?
Sir, tibial.
Not tibial. If the tibial nerve is dying, you get a main pain in the calf.
Calf, sir.
The farthest nerve from the heart.
Sir,
the nerve which is most distant from the heart will be the first nerve to be affected because the blood is flowing from the heart till the reaches in the nerve peripherally, which is the farthest nerve, distalmost nerve. Or what are the nerves in the foot?
So, sciatic nerve.
Sciatic nerve is in the foot. Okay. You need to study the anatomy much more. No, it is a plantar nerves out there. So those are the nerves will be affected. So the rest pain you get in the foot.
Foot, sir.
Claudication pain you get in the
calf.
Okay. So what does it indicate? Claudication pain indicates what? You said something substance P and all. What do you mean by that?
Sir, due to less oxygen, the anaerobic respiration happens in this tissue, and metabolite of P substance is formed, sir.
So what?
So failure to wash it, remove these substances, pain.
Who is going to wash it away?
Sir,
and what is the role of P factor? What is it, P factor? What is it? And what is the byproduct of your anaerobic metabolism?
P substance of byproduct, sir.
So you see physiology of this claudication pain, you must understand. These are at rest, the blood supply is adequate, and exercise, the more demand, less blood supply. So anaerobic, right? So that lead to lactic dehydrogenase, the P factor, which acts with the glutaraldehyde, and that is going to stimulate the nerve endings and going to produce the pain. And who is washing that pain out?
Sir, sir.
No,
Increase.
when claudication pain, as you walk, the pain disappears.
Yes, sir.
How?
But, sir, vasodilation will happen and
Vasodilation.
opening up of the collateral, sir.
Very good. So opening up of the collateral, the blood is coming and it is
washed out.
So there's a lot of things to ask in the claudication pain, but since you are in the beginning, I'm not going to the detail. Okay. Good.
Yes, sir.
Sir, you can, Prabhakar sir, you can ask.
Yeah, no problem, sir. Yes.
And you said there's history of paresthesia means what?
Sir, pins and needles sensation in the foot, sir.
Pins and needle sensation. So how it you do? See, what are the other conditions you get a pain in the foot?
Sir, there are claudication of neurotic claudication, venous claudication, and arterial claudication.
All those will never produce a pain in the foot. So repeatedly saying claudication pain is a muscle crampy pain. The higher muscle in the thigh or the muscles in the calf is going to get.
Yes.
The foot, there are only two conditions you are going to get. That is because of the ischemia, you have a rest pain. The second one, you are going to get a diabetic polyneuropathy. So how will you differentiate these two?
Sir,
so pin prick pain or all that is the typical features of the diabetic neuropathy. Depending upon the which nerve fibers, C fibers or alpha fibers, which fiber is involved, you are going to get loss of sensation or the glove and stockings pain or the pricking type of pain. All this will be at least with the diabetes. So if you are saying the patient has a paresthesia, that is a point in favor of a diabetic neuropathy.
Yes, sir.
There is no gangrene, there is no demarcation, line of demarcation. So in a line of demarcation, you can get a hyperesthesia. So the gangrenous site will never have a pain if it is gangrene. Gangrene is a dead tissue.
Dead tissue.
So dead tissue cannot produce pain.
Yes, sir.
Because everything is dying there, no? You will
Yes,
not
sir.
have the pain. Your touch sensation will be lost. All the sensation will be lost. So be careful, and when we are putting how you are going to put this there.
Yes, sir.
What is pseudo-claudication?
Pseudo-claudication. I'm not aware, sir.
When the patient is having intervertebral disc prolapse.
Yes, intervertebral neurogenic claudication. Patient will have due to nerve root compression, sir.
Yes.
And patients, the pain is relieved at rest and particular attitude, so that the compression is reduced, the pain is reduced, sir.
So what is the cardinal features of a claudication pain?
Sir, patient pain increases only on exercise, sir.
So no pain at rest?
No pain at rest. Pain increases on exercise, and at rest again the pain disappears.
So,
and this is reproducible on
very good. What is venous claudication?
Sir, venous claudication pain is present after walking, but it is more of a heaviness kind of pain, sir.
Heaviness.
So
when you will get venous claudication?
So spastic. In case of chronic venous insufficiency and varicosities.
Varicosity will produce venous claudication.
Long standing, sir, with venous insufficiency.
It will never produce venous.
DVT also.
DVT will not produce a venous claudication. Per se, when the DVT is there, it is a painful condition.
Yes, sir.
Patient will have that. So, the similar mechanism, what you are saying for an arterial claudication, yes, the normal limb, see, after the DVT, as you said in the chronic venous insufficiency, or mostly post-DVT, they will go for recanalization. Yes, recanalization will not be sufficient, will not be perfect 100%. So, when the limb is at rest, so for example, 100 ml of blood is coming in. that 100 ml has to go back through the vein.
Yes.
So which is possible. So at rest, the vein will not have the pain. But when you are going to work, exercise, more blood is coming. So those blood cannot go back to the recanalized vein. So there you are going to get congestion and you are going to get a pain. So that is only venous claudication. So venous claudication is a feature of post-DVT.
Yes, sir.
Acute DVT, you are going to have the busting type of pain. That is a different kind of pain.
Yes, sir.
Here in the post-DVT, no pain will be at rest, but on exercise, the pain will be more because more amount of blood is coming. That blood cannot go back. So you are going to get a. And how will you differentiate whether, how do you, a patient can differentiate, is it an arterial claudication or venous claudication?
Sir, in arterial claudication, pain is dull aching, but whereas in venous it is a
Yes, dull aching. You have put as a crampy pain.
crampy pain, and whereas in venous claudication it is spastic kind of pain, sir.
What is the difference? Spasticity, crampy? The only difference, it is very difficult to, only difference is that time at which the pain disappears.
Yes,
the
sir.
claudication pain due to the arterial claudication, immediately after taking rest, the pain will disappear. 5 to 10 minutes, the pain will be disappear. But if it is needs to take either the change of position or taking more than 10 minutes for the pain to disappear, then you have to consider in terms of the venous claudication.
Yes.
So in arterial claudication, it will be immediate relief of the pain on rest. So that kind of immediate relief will not be there in the venous claudication.
Okay, sir. Negative
What is this painting, black covers, blurring?
Sir, this can be generalized disease, sir. So patient can have involvement of other arteries. Per se
What is
in the,
peripheral arterial disease? What do you mean by peripheral artery?
sir, artery supplying to the extremities of.
Is that? Aorta is a peripheral artery or?
Axillary.
Aorta is a peripheral artery. Yeah?
No, sir.
No. So whenever you have a peripheral arterial disease, you have two segments, aortoiliac, femoropopliteal.
Femoral popliteal.
So aorta is also a peripheral artery. All arteries other than which supplies the brain and heart are peripheral arteries. So when you say peripheral arterial disease, it is not only the artery which supplying the lower limb or the upper limb. It is in all the arteries other than the arteries supplying the heart and the brain. Okay, but is it a common? Where do you get with that arterial occlusion, peripheral arterial occlusion? What are the kinds of pain you are going to get? What is abdominal angina?
Sir, patient will have pain after having a meal, sir, due to occlusion in the mesenteric arteries, the celiac axis or the superior mesenteric.
But that history you are not included.
I've included, sir.
Okay, postprandial. Okay.
Postprandial abdominal pains.
Okay, okay. DOE means?
So dyspnea on exertion, sir. Patient can also have the involvement of a coronaries.
After how many hours of lunch the patient will have abdominal angina? Immediately after taking rice?
No, sir. After 30 to 40 minutes of consuming a meal, sir. So,
why there is angina in the abdomen?
Sir, after a meal for the absorption, the blood supply is more to the intestine and absorption, sir. For intestine
and there is more blood supply, you will get a pain.
So reduced supply, the pain will come, sir.
After eating, blood supply will be reduced.
Sir,
you must always understand the same concept. No pain at rest, pain on exercise.
Exercise, sir.
So when the stomach is empty, the required blood supply is less, which is sufficient. When the food is going to be there, more blood is required, more blood has to, but it is not there because of the occlusion, the blood is not coming adequately. So you are going to get the pain.
In blurring of vision, which artery is affected? In blackouts, which artery is affected?
Sir, in blackouts, common carotid artery involved.
Blurring of vision?
Blurring of vision, ophthalmic artery branch.
Ophthalmic artery supplies what?
Retinal
The
artery.
branch of? See, it's a very common question. Blurring of a vision. Vision is from where?
From eye, sir. Retinal arteries branch.
Retinal arteries. So
Yes, sir.
the central retinal arteries.
Retinal arteries.
Have you elicited the history of importance in this particular patient?
Yes, sir.
I don't think it's so. I have not
No,
seen.
he has said family history. He said he is married and having children. Okay.
Yes, sir.
Okay.
Why should we elicit the history of
No,
importance?
but the importance. Okay. Why? Sorry, is asking why.
In what way it is related to PVD?
Sir, the penis is supplied by internal iliac artery, sir, which is a branch of a common iliac artery. So in case
internal iliac artery is not directly supplying penis. What is the artery supplying penis?
inferior mesentery.
It's a branch of internal iliac artery, but you should not say internal iliac artery, and which is
internal pudental artery, which is a branch.
it's not, it is coming and supplying internal directly, or it is a branch again.
Branch.
Which is what are the arterial supply to penis?
Internal pudental. After that.
Internal pudental will not come there, but it is only again a branch of that. It's a dorsal penial artery.
Dorsal.
Superficial and deep dorsal penial artery. Branches are there. Okay.
What is Lerich syndrome?
Sir, Levin syndrome is involvement of thigh muscles, hip muscles, along with impotency. Sir.
Three components are there. What are those three components?
Sir, obstruction distal to the bifurcation, causing claudication pain in the gluteal muscles, thigh muscles, and the hip area, sir, along with
absence of femoral pulses, bilateral gluteal claudication, and
impotence.
What is saddle thrombus?
Sir, thrombus from the aorta entering into bilateral common iliac, sir.
Why it's called a saddle thrombus?
So it looks like a saddle, sir. Bifurcates.
What is saddle?
Saddle is the way that you put on a horse.
Good, very good.
Yes. You have an abdominal angina. It is due to what kind of occlusion? Is it a thrombus or embolus?
It can be thrombus or embolus.
Very good.
Embolus
So,
will be.
what will be the feature of a thrombus? What will be the feature of embolus?
Sir, embolus is sudden pain started, sudden occlusion causing a severe pain, sir. Whereas
so how much occlusion will be there? Is it which is reasonably good? You have a thrombus or embolus?
Sir, embolus, sir, occluding completely.
It's good or bad?
Bad, sir. It has to be removed immediately too.
Thrombus need not be removed.
Thrombus also has to be removed, sir. But it is a
chronic. Thrombus is more dangerous than embolus. Embolus will go to the peripheral artery. If suppose it is a superior mesenteric artery, it will not block this superior mesenteric artery. It will go and block one of the small branches. So the area of the ischemia going to developing will be the small. But thrombus always develop at the origin of the vessel. So superior mesenteric artery origin. So then the entire bowel will go for a gangrene when it is blocking on that.
Yes.
So you are not talked only about the something about claudication pain, and you have said something called night pain in the history. Previous slide.
Yes, sir.
What is night pain?
Sir, it is a rest pain, sir, in the evening.
There is no term called rest pain equal to night pain.
Sir,
Rest
night
pain is 24 hours.
Yes, sir. Night
What do
pain
you mean by night pain? Night pain is a very definite pain you get in
Yes,
one
sir.
condition.
Sir, night pain, when a patient sleeps, the heart rate and the BP, physiologically, the heart rate and blood pressure goes down, sir. So the oxygen supply will be reduced to the affected, already occluded part of the limb. So patients start having pain in the night, sir.
No, that is, the pain makes them not to sleep.
Not to sleep, yes, sir.
That is not night pain. So night pain is a typical feature of a varicose vein. When the patient's lying down, he gets a severe pain because both the foot pump and calf pumps are not working. At least when you are standing and working, your foot pump will work. So the blood will be going. So in the night, you are not going to get because the foot pump is not working. So the patient will relieve the night pain by compressing on a bed or compressing on the wall with the foot. So the pain will be disappearing. So the term night pain is reserved for a varicose vein pain. Not for this pain. Here you must only say it is a rest pain because the rest pain make him not to sleep.
Yes, sir.
It is not the night causing the pain. Because of the pain, he is not able to sleep. That you can say.
Okay.
And how will you differentiate? Earlier I asked the question. This patient has a diabetic mellitus for a long time.
Yes, sir.
And the rest pain. How do you say it is only due to ischemic pain, not due to the diabetic neuropathic pain? Because you already said the answer, you are already put it. So here you are very sad by hanging the leg down.
Yes, sir.
The pain is less.
Less, sir.
That means the blood is coming out, the pain is reduced. The neuropathy pain will not change with a change of position.
Change of position, sir.
And it will be the prick and sensation or the glove and stocking type of pain will be there. So this patient is only 44 and he is having a diabetes.
Yes, sir.
Then what is the diabetes can produce an atherosclerosis?
Yes, sir.
So what is the difference in diabetic atherosclerosis and other atherosclerosis?
Sir, diabetic atherosclerosis, it is more of a cholesterol atheromas that are present, sir, mostly.
That is a definition of atheroma. Atheroma is always high cholesterol and cells we are going to get.
Yes.
Have you heard the term Mangiberg sclerosis?
Yes, sir.
So where do you get atheroma? Which layer of the, what are layers of the vessel?
Sir, intima, media, and adventitious.
So where do you get a normal atherosclerosis?
Intima, sir. Intima layer.
So what is Mangiberg sclerosis? Or the diabetic mellitus? The most often the atheroma formation will be in the media, not in the intima. And it will be earlier than the normal atherosclerosis in a patient who is having a 60, 70 having atherosclerosis. But diabetics, it will be much earlier. The most commonly it will be in the media. So that is why it is very, very diabetic patient developing a ischemia. It's a very, very dangerous condition which you are going to get in. Okay.
Sir, can I go ahead with the examination?
Okay, go ahead.
So, general physical examination. Patient is conscious, oriented, moderately built, no pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy. Pulse.
Can you put the previous slide, the picture of the patient? Okay. Okay, go ahead. So can you get edema in atherosclerosis? I mean, your peripheral artery disease.
Sir?
Can you get edema in an atherosclerosis, I mean, peripheral vascular disease?
Yes, in the above the area of line of demarcation, we might get
We don't get that. We are talking about pedal edema.
pedal edema. No, sir.
No. Yes, doctor. The two conditions you can expect. One is thromboangiitis obliterans.
Yes, sir.
Because it is not only a disease of a vein, I mean,
Vein,
artery,
artery.
veins can also be affected. So, if there is an associated pedal edema, more in favor of the second thing you said already, the patient hangs his leg down while sitting and everything. And when the leg is hanging down for a long time, the venous return will be also impaired and you can get an edema.
Edemas. So pulse 98 beats per minute, regular, normal volume, no vessel thickening in the right radial artery, and it is normal in the left radial artery also. BP is 130 by 80 millimeters of mercury. It is same in the both the right and left upper limbs. Respiratory rate is 18 minutes per minute, A febrile. Local examination, inspection, attitude, patient sitting on the cot with both the limbs hanging down. Dry gangrene of left foot and a distal half of the leg with a line of demarcation present. Skin of the left lower limb is dry, lusterless, hairless, with brittle nails and mummified toes. Signs of skin. Pregangrenous changes noted above the line of demarcation.
Can you show in your picture the line of demarcation? What is the line of demarcation?
Sir, in the mid.
No, you have a
mid
cursor, no? You show that with the cursor.
Sir.
That is not line of demarcation. See, line of demarcation is a feature of dry gangrene. Here you don't see the gangrene. It is a color change is only there. There means dry gangrene and living tissue. It is a space between the dead tissue and living tissue.
Yes, sir.
And you will see that will be noted by hyperesthesia, hypervascularity, and the tissue. There is no area of line of demarcation because this is not gangrene at all. So this is not acceptable for a postgraduate if you cannot differentiate a gangrene, dry gangrene, and your line of demarcation. You need to spend time in clinical examination, see the case, and what is line of demarcation, what is line of separation, and you have also put toes are mummified. What do you mean mummified?
Sir, dry and shriveled, sir.
What is dry? What is shriveled? So which limb you are showing that is dry and shriveled?
Sir, left limbs.
Is it dry and shriveled? Don't use your language terms which you are studying in a textbook in the clinical examination. You see and what is there, and then you will not make any mistake. Only when you try to bring in whatever you learned into this, then you will find it. Here there is no area of shriveling.
Yes.
So I again repeatedly say for the postgraduate, in the examination, what we are looking for is your clinical observation, what you are going to say. In this case, if you come and say there is a dry gangrene is there, the line of demarcation is there, shriveling and mummification is there, that is cannot be accepted. Okay? Go back. Go to that slide.
Patient has severe pain on slight movement of the left lower limb, sir. No dilated veins seen. Right lower limb skin.
But which you have never said in your history. Even a slight movement is producing pain. See, now you are suddenly bringing severe pain on slight movement. Is it a pain or tenderness?
Sir, pain, sir.
Pain. So what is the difference between pain and tenderness?
Sorry, tenderness, sorry. So pain is tenderness is sign, sir.
So inspection, you are going to see only the signs, no? We can't talk the symptoms in the inspection.
Yes, sir.
Hmm.
Sir, right lower limb skin is dry and reduced hair.
And you are going to look for a dilated veins in a peripheral arterial disease. You expect the veins to be dilated when there is a blood supply is very low there?
No, sir.
Then why do you want to write as a no dilated veins?
Sir.
Okay. No, this is both the limb has this one. This is the right limb also. We have put something. Skin
Yes,
dry.
sir. Yes, sir. Right limb also distally is skin in the foot. Skin is dry and reduced hair is there, sir. Loss of subcutaneous tissues.
How do you measure reduced hair?
Sir.
How did you measure there is a reduced hair? What is the normal hair you were expecting in a leg?
Sir, cluster hair is.
No, reduced hair. How do you come to that conclusion?
Sir, as in comparison to other.
Comparing that side, there is no hair.
Yes.
And this hair, there is a reduced hair. How do you come to compare?
Compared to the upper limb, sir.
Upper limb and leg will have a same kind of hair?
No, sir.
So never make this statement of hair is there because we have not seen the patient earlier. If the same patient, if you have seen earlier, then it is fine. And you have a picture of the patient earlier saying that there was a lot of hair there and now the hair is lost.
Okay.
See, clinical in a inspection, tell what you are seeing.
Okay, sir.
Loss of subcutaneous tissue in the left side also.
In the right side also, sir.
Right side also.
Yes, sir. Sir, on palpation, limb is cold till the knee, sir. Tenderness present in the left calf and the knee region.
Which limb?
In the left limb, sir. Affected
which limb?
In the left limb, sir.
No, because you are confusing here and left, right, both you are putting. At least then you should put the capital and examination of the, and there is nothing called local examination.
Yes, sir.
Always you must say examination of the lower limb.
Lower limb.
It's not the term, it's not just a local examination. So
yes,
what
sir.
you are going to, so you have to say on examination of the left lower limb.
So there's a loss of sensation in the gangrenous part of the limb, that is the lower half of the leg and foot, sir. The girth of mid-calf region, right side it is 24 centimeter, and the left side it is 24 centimeter, and left side it is 23 centimeters. In mid-thigh region, it is equal in the both sides, sir. No dilated veins, no palpable inguinal lymph nodes, sir. There is normal movement at the hip and the knee, sir, but there is no.
What are the movement of the hip?
Sir, flexion, extension, abduction, adduction, internal rotation, and
adduction. Movement of the hip.
Sir, flexion, extension.
What is hip joint?
Sir, hip joint is a ball and socket synovial joint, sir.
So why do you want to examine the hip joint movements here?
Sir, in case
the examination, it will be given only 40 minutes or 30 minutes for you to examine.
Yes, sir.
And you need to see only for obvious things you need to see.
Yes, sir.
So mid-calf, how do you know it is mid-calf? Where do you measure to say it is a mid-calf?
Sir, from 10 centimeters below the tibial tuberosity is.
Very good. Okay. There is no obvious difference, but your picture shows there is a lot of. Go to the picture.
Yes,
see that limb, previous slide.
Yes, sir.
Show the previous slide. No? See the size of the calf. It is like an inverted champagne bottle. So
Yes.
much style. Okay. See, in this picture, we will see at least in the toes there is gangrene.
Yes, sir.
It is not the gangrene out in the there. That area, left 3 toes.
Yes, sir.
So that is relatively, you can call it as a gangrene, and you must look for the line of demarcation only there, not in the calf. What the color change, what you are seeing above is not a gangrene. It is only a color change.
Allergy.
Hmm?
Sir, here the foot also here it is fully blackened, sir, in the plantar aspect also.
Okay, again, there is no line of demarcation.
Okay, sir.
Line of demarcation is separation from the normal tissue
Normal
and
tissue.
the dead tissue and living tissue. It belongs to whom? Line of demarcation belongs to whom? It is like a line of control, what we are saying in the borders of our country.
Yes, sir.
It belongs to dead or it belongs to living?
Dead tissue, sir.
No, it is always a living tissue. So there is a separation. The living tissue trying to grow towards the dead tissue is not what we are going to see. That is why that tissue is a newer tissue, new generating tissue that will have hyperesthesia. It will be a hypervascular area. So that belongs to the living tissue.
Living tissue. Okay, sir.
Okay. Hmm.
Sir, right foot also cold compared to the right leg, sir.
Right foot is also cold.
Cold, sir. Sir, on the left side, all the distal pulses below femoral are absent, sir. In the right side, distal pulses are feeble in the dorsal pedis artery, anterior tibial artery, posterior tibial artery, and popliteal artery is feeble, sir. Femoral artery is palpable bilaterally, sir. Aortic pulsation felt
So
just.
you could feel the aortic pulse.
Yes, sir.
You could feel the aortic pulsation also.
Yes, sir. Patient is abdomen is not obese, sir, so we could feel the aortic pulsation, sir.
Why do you want to feel the aortic pulsation?
Sir, to see if the thrombus is extending from the bifurcation till below, sir.
If there is a thrombus is there, how do you get a femoral pulse?
We won't get, sir.
See, clinical examination is something which you needed to do, not that all the tests we are going to do. When you say the femoral pulse is felt, there is no point in saying that I am going to look for the aortic pulse.
Okay, sir.
That is your waste of time. See, we are expecting you within the 30 minutes and what maximum you can do.
Yes, sir.
So where do you feel the femoral pulse?
Sir, midpoint of anterior superior iliac spine and pubic symphysis.
Pubic symphysis. No, always the femoral pulse is felt against something, hard object.
Sir,
Against which bone you will feel it?
pubic.
Pubic bone.
Sir, sorry. Femur, sir, neck of femur, sir. So bilateral superficial temporal, carotid, subclavian, axillary, brachial and radial artery are palpable and equal, sir. On auscultation, there is no bruit heard on the left and the right side, sir.
Where you heard the bruit?
Sir,
Where do you
resistance.
look for bruit?
Sir?
Where do you look for
Distal,
the bruit?
sir, distal to the occlusion, there will be bruit, sir, because of.
Distal to the occlusion.
I'm sorry, sir. Proximal to the occlusion because
So
the.
where is your occlusion? Where is your occlusion?
Sir, occlusion is in the popliteal this thing, sir.
So where do you look for the bruit?
Sir, in femoral, superficial femoral artery.
So you cannot just put no bruit here because bruit is not normally heard anywhere.
Yes, sir.
So you must be specifically saying where you look for a bruit and whether you heard the bruit or not.
Okay, sir.
Have you palpated the dorsalis pedis posterior tibial?
Yes, sir. I've palpated, sir.
Where you have palpated the dorsalis pedis?
Sir, dorsal pedis artery is palpated lateral to the extensor hallucis longus, sir.
Against which bone?
Sir, against talus bones.
Talus.
Navicular, sir. Navicular
Only
bone. And posterior tibial artery is felt behind the medial malleolus, in between the tibial malleolus, medial malleolus, and the insertion of tendo Achilles.
90% of the blood supply to the foot is by which artery? I will give three options. Dorsalis pedis artery, posterior tibial artery, anterior tibial artery.
Posterior tibial artery.
Yes, you are correct. Posterior tibial artery. Where will you palpate the anterior tibial artery?
Sir, in between both the malleolus against the distal tibia, sir.
Okay.
And head of distal tibia and head of talus, you'll find the anterior tibial artery, sir.
Where you have palpated the carotid artery?
Sir, against C6 vertebrae in the anterior sternocleidomastoid, sir.
Against one tubercle in the transverse
Carotid.
fossa.
Transverse fossa of C6, sir, carotid tubercle it is called.
where is it? At
Sir,
what level is carotid tubercle?
carotid, sir, mid this one, sternocleidomastoid. It is
Which cartilage?
the thyroid cartilage, sir.
Thyroid cartilage?
Yes, sir.
What's the lower end of the thyroid cartilage?
Sir,
Which vertebra it belongs?
C6, cervical vertebra, sir. C6.
C6 is not thyroid cartilage. C6 vertebra is the most common site where lot of anatomical changes taking place.
Yes, sir.
It belongs to what cartilage? It belongs to cricoid cartilage. What are the other anatomical changes taking place at C6 level? The larynx becomes trachea.
Trachea, yes.
At the C6 level, the pharynx becomes esophagus, that area. The carotid bifurcates above that level. That is why you are going to, which artery you are palpated? Which carotid? Common carotid or external carotid?
Common carotid, sir.
So common carotid should be felt below that area.
Below.
Okay.
Yes, sir. Sir, systemic examination, cardiovascular system, S1, S2 heard and no. Respiratory system, normal vesicular breathing sound. Abdomen, soft, non-tender. There's a healed scar in the left iliac fossa due to previous surgeries. Central nervous system, there is no focal neurological deficits.
So you said already there is a pinprick, paresthesia.
Yes,
they
sir.
are all focal neurological deficit or not? Your patient had a paresthesia. Your
Yes,
patient
sir.
had pinprick sensation.
Yes, sir.
So then how, now you say there is no focal neurological deficit? You can only say if there is an obvious neurological deficit or obvious deficit. Focal is a very limited one which you are going to examine there.
Yes, sir. The case summary, 42 years old, known diabetic and smoker with claudication pain, progressing to rest pain with dry gangrene of left foot and absent peripheral
toes, left distal lateral 3 toes.
Yes, sir. Lateral 3 toes and absent peripheral pulses distal to the femoral artery, suggestive of critical limb ischemia of left lower limb secondary to peripheral arterial occlusive disease of thromboangiitis obliterans etiology.
What is the definition of critical limb?
Sir?
What is the definition of critical limb? When will you call a limb as a critical limb? Critical limb ischemia.
Yes, sir. When there is no intervention intervention has to be done.
No intervention to be done.
Intervention has to be done, otherwise there will be irreversible changes to the tissues. That's
Critical limb ischemia.
What is the new terminology? What is the new terminology? It is not now we don't use the word critical limb ischemia. It is a limb threatening ischemia.
Yes, limb threatening.
So it can be chronic limb threatening ischemia or acute limb threatening ischemia. So you must know the classification, staging, acute limb threatening ischemia, how you are going to stage Rutherford staging for a chronic limb threatening ischemia. Okay.
0 to 6.
Okay.
Why do you say it could be due to TAO etiology? Why can't it be due to atherosclerosis?
Sir, it is more in the medium and small arteries he has having in bilateral, sir, and thrombus.
What are the criteria to have a TAO?
Sir, 20 to 40 years of age, sir.
Not 20 to 40 years. You cannot change the criteria as per your convenience. Age less than
40 years is common in TAO. Male predominance, smoker, and
what is the most important thing? They should not have an associated comorbidities.
Yes,
your
sir.
patient is a diabetic for a long time.
Yes, sir.
So you can never put that as a TAO as the diagnosis there. And if you have a bilateral lymphedema is there and upper limb is involved, all those are an additional point to say. So in this case, there is no edema, nothing. He is a chronically diabetic patient.
Yes, sir.
So you must only think in this diabetic lymph.
In TAO, only arteries are affected or veins are also affected?
Sir, arteries, veins, and nerves are also infiltrated, sir, because it is a pan. This thing, sir. Pan vasculitis, it involving the surrounding structures also, sir.
Is it a pan vasculitis or pan arteritis?
Pan arteritis involving.
What do you mean by pan arteritis?
Sir, all the layers of the
layers of the
arteries
associated with venous edema. It is not the pan vascular. Okay.
Yes, sir.
So why not? It is a simple diabetic foot. Diabetic foot can be neurogenic and ischemic.
Ischemic, yes, sir.
So what do you get neurogenic diabetic foot?
Neurogenic. Sir, here gangrene set-ins.
Due to what?
Occlusion in the blood vessel.
No, I am asking neurogenic diabetic foot.
So neurogenic?
See, your patient had a peripheral neuropathy. Your patient has pinprick sensation. Your patient has almost a continuous pain. And why what do you mean by diabetic foot or neuropathic diabetic foot? Which nerve is affected?
Peripheral.
Is it a sensory nerve, motor nerve?
So sensory is affected in the diabetic.
So motor is not affected.
Motor also involved at the later stages, sir, where foot deformity.
How do you know this patient had a motor is affected or not?
Sir, foot deformities are set in, sir, with
what deformity?
Charcot deformity.
Charcot is entirely different. This diabetic foot and Charcot is a different terminology. So all the three nerves will be there. Motor neuropathy is the small muscles of the foot will be affected. So it will produce a clawing of the hand, clawing of the foot.
Yes.
So your patient also has a clawing foot. And your patient will have sensory neuropathy. And third is an autonomic neuropathy. You said your limb has lusterless. It's dry.
Yes,
why
sir.
it is dry?
Vasomotor.
So the sympathetic nerve is also affected.
Affected.
So all the three will be producing diabetic neuropathy. So this patient is also having an ischemic changes.
Ischemic changes.
So what kind of ischemia will be set in diabetic?
This thing, microvascular.
Okay, you are not prepared for diabetic foot, so at least you would have prepared for peripheral arterial disease. So how you are going to manage? Because time is up. You'll finish.
So this presented after 3 days of...
Previous slide.
Sir.
All the four diagnoses, sir. What is the dry gangrene of the left lower limb? Is it a diagnosis or a finding?
Finding, sir.
So you can bring a finding into diagnosis. No, these are very, very grave mistakes, Nitish. Postgraduate, we don't expect to play in the examination. Huh? We don't want a PG come and say dry gangrene of the left lower limb is a diagnosis. And there is never there is a statement called peripheral arterial occlusive disease. That is also, it is a generalized statement. There is a big chapters are there. And you must be able to say the critical limb ischemia, or in this case, which limb and which segment is involved. It's a femoropopliteal segment of the which limb?
Of the left limb, left lower.
Not like this.
Yes. Sir, the investigations, I would like to do a CBC.
Why? Why do you want to do CBC?
Complete blood count, sir, to see if they...
is it the first thing you are going to do?
Sir, in this case, I would like to do a Doppler, sir.
So always you must be, again, the postgraduate, it is your, when you are asked for the management, the first thing is confirmation of your diagnosis.
Yes, sir.
All that clinical routine, CBC, all that is not, that all come only when you are going to deal with the patient, treatment part.
Yes,
the first component of you is only a diagnosis, where you are going to do the Doppler.
Doppler.
So, why do you want to choose Doppler only?
Sir,
what is Doppler?
Sir, Doppler is the ultrasound using the sound waves. So, sound waves.
No, go slow. No. Doppler is also an ultrasound.
Sir, Doppler is the ultrasound waves which are transmitted or reabsorbed, sir.
So what is ultrasound then? Ultrasound examination means? What do you mean by ultrasound examination? USG?
Sir, sound waves used to...
So that there is a sound wave and this is ultrasound. You must say, what is ultrasound? When will you call a sound as an ultrasound?
Sir, high frequency, which not be...
What is the unit of the sound?
Hertz.
Hertz. So which hertz is called as a ultrasound? The sound which is not audible to the ear is called ultrasound. Up to 2 megahertz or 20,000 hertz is audible. Any sound which produces more than 20,000 hertz is called as an ultrasound. Both Doppler and ultrasound use the ultrasound waves only.
Yes, sir.
Then what is the difference?
Sir, waveform of the...
In both ultrasound examination, the sound is reflected back by the static object.
Yes, sir.
But in a Doppler is an ultrasound of sound reflecting by the moving object.
Yes, sir.
By that sound, we will be able to say whether the object is moving towards you or moving away from you. So we keep on the hand. If it is an artery, the sound will be increasing or decreasing?
Sir. Increasing, sir.
Increasing. So by knowing the sound, you will be able to say this is an artery. Similarly, you can say it is a vein. So Doppler is always reflecting. So the ideal examination is a duplex.
Duplex.
Combination of both.
B mode and Doppler.
What is B mode?
Sir, B mode is the...
What B stands for what? See, ultrasound is a stethoscope for a surgeon. So you must know all the details of an ultrasound. And you must do ultrasound. Postgraduate, before you complete your examination, you must be able to confidently do the exam with the ultrasound. Spend some time, because doing an FNAC or any other procedure, that you have to be a master of that.
Yes, sir.
So B is a brightness mode.
Brightness mode.
Okay. So what are the things you get in the Doppler?
Sir, the tissue surrounding the surrounding vessel, along with the flow of the blood, sir. And
Tissue surrounding the vessel will not be seen by Doppler.
sir, in the B mode, the vessels are visualized.
That is why if you would have put as a duplers, that's a combination. Doppler is only you are going to see the moving object.
Okay. Yes, sir.
Okay, the time is up, so we are not going to the details. Okay.
Yes, sir.
So what you will do for this? Can you stage this disease?
Yes, sir.
Rutherford.
Sir, Rutherford. Sir, it's grade 4.
Okay.
Will you take angiogram for this patient?
Yes, sir. We have done the.
What are the 5 or 6 things? If I am giving the angiogram picture,
yes, sir.
What are the things you will see in that picture? Site of
the obstruction.
Size of the obstruction. Signs, whether it is
thrombus. Yes, sir. Short segment involvement or long segment involvement.
Yes.
Distal runoff. Collaterals surrounding the occlusion.
Yes. Run in, run off, collaterals. Everything. Okay. Yes. So what are the other investigations you will do? One is Doppler, duplex.
Then angiograms, CT or MR angiogram. Because
what is ankle brachial pressure index?
Sir, ankle pressure, sir.
ABPI.
Yes, sir.
In your case,
systolic blood pressure in the upper limb and the lower limb are taken, sir. And the ratio, if it is less, if it is more than 0.9, it is normal. This thing, sir. If it is 0.9 to 0.5, it is mild ischemia, and 3 to 5 is severe, and less than 5 is severe ischemic limbs.
Okay, in your particular case, how will you manage?
Sir, after the CT angiogram, there is no flow distal to the superficial femoral, so I would like to go for aboni amputations at the level of mid-thigh.
Before that,
Sir, if patient was presented in the window period of initial 4 to 6 hours, we could have planned for thrombectomy and salvage the limb, sir.
Aboni amputation you are going to do for this patient? Any medical management?
I don't think it will be justified in saying it's a below amputation for this patient, because we are seeing only a distal lower gangrene. Whether you must use all the invasive procedures. You know what is task and Wi-Fi score?
No, sir.
Okay, so that depends upon the task. That's originally it was task criteria alone, but now it is more than that. Is a Wi-Fi wound infection area of ischemia. So that score is going to only decide whether what kind of surgery you are going to do for the patient. So go and read.
Yes,
basically on the you have to read, brushing up yourself with the anatomy. Because what normally we will go into the picture and what are the arteries we are seeing in the CT and what are all the things you must know. And what are the surgeries you must learn. And also you must know what are the complications of the surgeries which we do. Compartment syndrome.
Yes, sir. Reperfusion injury.
Reperfusion, that thing. And angiosome. What do you mean by angiosome?
Sir, is it the extravasation of the dye?
It's a 3D model of the area of the supplying.
Okay.
We have 3 vessels mainly supplying that area, no? Anterior tibial, posterior tibial, peroneal, and not the area supplying. All that will be spend some time and read. Now it's a time for you to go read Swartz, read all the textbook and make notes of you. That
Yes,
will be ideal. Also refer, there is a beautiful publication of peripheral arterial disease. A book is there, and or the recent guidelines on the peripheral arterial disease, American guidelines on the peripheral arterial disease. That will also tell about conservative management and when to operate, when not to operate, all the things.
Yes, sir.
All the best.
Thank you, sir.
All the best.
Thank you, sir.
Yeah, thank you.
Prabhakar sir, Kanna sir.
Yes, sir.
Any other comments, sir? Can we call a close, sir?
Yes, sir. We can call.
Thank you, sir. Thank you, Jalal sir.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir.